impulses, that's still okay, apical displacement. But if it had nothing to do with palpation, it's still okay. But if it had to do with palpation, they're expecting you to say everything at one shot. So now let's say we move on to the percussion of the chest. We say, I would like to check for any dullness or hyperresonance. Okay. Then I'd like to go ahead, auscultate, and listen to the heart sounds for S1 and S2, and I would like to also use the bell of my stethoscope to listen for S3 and S4. Is there any abnormalities? Heart sounds are normal and clear, without any murmurs. Great. Then you go ahead and listen to the lung sounds in the anterior chest for bilateral air entry, or any abnormal lung sounds that might be present. That's the anterior chest look. We're not talking about the posterior chest right now, okay? So once you listen to it and it's clear, you're going to move on. But if they say, let's say, for example, you have on percussion of the chest hyperresonance in the anterior, now you got to listen. You got to put that down. No, jot that down quickly on your paper, because this hyperresonance by itself is a sign of some sort of air trapped in the pleura. Right? Dullness is a sign of mass, fluid, or something like that trapped. So write that down, because this is going to determine you moving forward to build differentials. Once you finish from there, then you say, okay, so we did the GVD, so we don't have to, because we came in order, right? Now I'm going to go from chest down to the abdomen. What am I looking at the abdomen is I'm looking for basically, so I would move this from here. Actually, no, I wouldn't move this. I would keep this for you guys here, but just to make sure that you guys understand that we already did the neck. So if someone has a problem with JVP, what are you going to do later on for him? This is just for that, to make sure that you understand it, okay? But we already did the GVD as we were coming down the neck. Another thing we'll do is we'll go down to the abdomen, right? So now in the abdomen, I would like to go ahead, auscultate for basically abdominal aortic, and see if there's any abdominal aortic aneurysm, or listen to the renal for any renal bruits and iliac bruits if there might be present. Then I'll go outside of that, then I go to the hands. I say I would like to check the hands for any signs of nicotine staining, any decrease in capillary refill, or increase basically for any signs of clubbing, chylonchia, or something like that, right? And splinter hemorrhages if you're looking for something like endocarditis. After that, then you're going to go to the sacrum. You will say, I'd like to perform a palpate for pedal edema or sacral edema that might be present in the peripheries. And that's it. Then you can say, you know what, thank you so much for your cooperation. I will close my case by thanking my patient, and I would like to go ahead and perform some physical exam. Take some history later on, and also order some imaging studies and lab work. That's it. And then your post-encounter starts. So this is for cardiovascular. Now let's say if we go to the posterior chest, how are we going to perform a lung examination? As I said, all the first 5 stuff is going to be the same. Sanitization of my hand, asking for introducing myself to my patient, asking for permission from my patient, draping my patient, and as well as asking for a chaperone if needed. And then I'll go general appearance exam. So if it comes to labor and general appearance exam for a respiratory patient related or heart related, both of them are almost similar things that you can say. Labored breathing, accessory muscle use, peripheral cyanosis, or posture, pursed lip breathing, for example. This is a very good way to put a general appearance exam for your patients, okay? And then you go check the posterior chest, right? Same thing. I start from the eyes, go to the nose, go to the mouth, and go to the neck. So if I go to the, I think I explained this one time, so now I think you guys are much more familiar with it. For saying I would like to check for pleural actress, I would like to check for nasopharynx. Say all at once, as I said, to find out any abnormalities, okay? Don't say each one separately. It's going to eat your time out. And then finally, as we go down, we're going to go to the neck. So when we go to the neck, we're going to look for, of course, in here, I'm not much worried about carotid bruits, or I'm not worried about GVD. Sure, it can be up, but if it was more related to cardiovascular condition. But the most important when it comes to respiratory condition, I'm worried about tracheal deviation. or I'm looking for some sort of cervical lymph node, cervical lymphadenopathy because I want to exclude a possibility of an infection or something like that, right? So that's why it's important to perform a lymph node examination for respiratory exam, and check for tracheal deviation as well to check for possibility of any, basically, or what do you call that? Pneumothorax or atelectasis or something like spontaneous pneumothorax. But anyway, a lot of you doctors have the good understanding. All I'm doing right now is just putting these in organized fashion for you on how you're going to ask questions on these respiratory issue cases, okay? And then you go to the back of, do the same thing, inspect, palpate, percuss, do vocal tactile fremetis, percuss, and auscultate. The problem is that when you see these things like auscultation, you have to know, what does an abnormal breath sound, like decreased breath sounds on the right side, mean to me? If it's decreased breath sounds on the right side, it means there's some sort of consolidation out there, right? So now I gotta know, what other tests should I do for consolidation? Like, for example, eugophony, bronchophony, bacterial wheezing. So these are the most special tests that we have to do after we find certain things like increased breath sounds, decreased breath sounds, and things like that. But if you really don't even know, at least perform it. It will help you. You'll figure out what's going on. And they will give you an answer. But just wait for their answer to see what it is, right? And write it down in your paper. Because in the end, when the post-encounter question comes, you can look at it and just say, okay, so my patient had dullness, he had decreased breath sounds. I need 1 minute to think about this, or I need 10 seconds to think about this, sir. Okay, no problem. You look at it and you think about it. That's why it's very important, okay? Don't rush it. You have 3 minutes in the post-encounter. Once you got your positives, take it, look at it, and wait. Take as much as time, even it could be like 30 seconds, 40 seconds. Think about it. Don't just toss a question just randomly, answer to the examiner or like that. But at least you do want to make sure that you do understand what is the point of vocal tactile fremetis. If it's increased, what are you looking for? If it's decreased, what are you looking for? And all these things, right? These are very important. And after that, okay, so another way that I wanted to make sure that I can, some of the doctors might know about this, that have worked, we have had classes, or we had like mocks, I told them about this, but some of you might not be familiar with this. When it comes to physical examination, they're not just going to give you something like, oh, go perform a chest examination, or go perform a respiratory examination. They will give you a very tricky scenario. They will tell you, hey, you know what? A 35-year-old patient presents with a complaining of cough and shortness of breath. Please perform a physical examination. That's all. Or they will say a 65-year-old patient presents with leg pain. Perform a physical examination. Now you're not sure. You're like, what the hell? Dr. Quadri told me that, do respiratory like this and physical exam for shortness of breath like this. And what the hell? This guy, I don't even know what to do. So don't lose yourself. Do the same thing as I said. General, like all these sanitizing questions and hygienic questions that all these main up to general examination appearance point, up to that, everything is the same. After this, whatever the chief complaint is, if it's leg pain, go to the leg. Start from there. See, like, okay, I want to inspect the leg. I want to palpate the leg. I want to go ahead, move the leg to see for range of motion. I would like to go ahead and do the sensory examination. I'd like to go check for the pulses. Once I'm done with the leg, then I will figure out that, hey, you know what? This is possibly leg pains could usually be either arthritis related, it could be either DVT related, it could be swelling related, and it could be heart related. Then you can go outside and just start to perform small little tests. But at least initially go to where your chief complaint is. Because it's not going to be easy that you start to know that, oh, everything is heart related. No. First, go to your leg, find out what's going on with that leg. Once you find out, then that will help you kind of say, hey, you know what? Okay, now I see that there's swelling. Let me go ahead back to the lungs. Do a good auscultation. Find out if this patient has PED or something like that. PE. Check for respiratory rate, the vitals, look at my vitals as well. Okay, let me just perform some sort of percussion to see if there's no hyperresonance or exclude the possibility of pneumothorax. So when you get the 2 minutes for the physical examinations, I recommend you write some good differential diagnosis first. Think like you're taking a history. Think like that, okay? When you just write that differentials, that gives you the ability to perform certain tests that are needed for physical exam. Right now, what I'm telling you guys is a complete system examination, but that does not mean the exam is going to come and tell you that complete, oh, do the complete examination of this system. No, they'll give you a random question. They'll just give you, oh, okay, a 35-year-old man is having hearing loss. Please perform physical examination for this guy. Okay, I will do that. But first of all, I'll do the same way. I'll sanitize my hand. I'll ask for permission. I'll go ahead and basically explain to my patient what I'm about to do, drape my patient, and have a chaperone present. And then I would like to go ahead, check the, ask for my vitals. If the vitals are good, perfect. After that, I'll go ahead, perform a general appearance exam, perfect. Now the problem is what? Hearing loss? All right, let's go back to the cranial nerves. Or start from cranial nerve 8. That's what I will do. I'll start the examination. First of all, I would like to spec the head and neck and see if there's any kind of trauma. I'd like to palpate around the ear to see if there's any pain, pull up the pinna to see if there's any pain. There's none. I would like to also check for some discharge if there's present. And then I'd like to go ahead perform a Weber's and Renee's test. If that's perfect, it's good. I would like to go ahead perform the other cranial nerves now just to make sure like I'm showing that I'm doing neurological exam. I'd like to perform some motor. You see how I didn't even know. I went to the ears, I did some inspection, palpations and stuff like that. Checked the lymph nodes around it. All of a sudden I figured out, oh damn, I'm doing neurological exam. Okay. Then you go ahead and you perform motor movements and just some cranial nerve exam and that's it. What else can you do? What can be the possible most common cause of hearing loss? It's either problems with conductive, sensory, or some sort of stroke, or some sort of cranial nerve damage, right? Or some sort of electrolyte abnormalities. But how do I perform the electrolyte abnormalities? I don't even know. But by just doing motor movements, it can tell me that if the patient's spastic, if the patient's has rigidity, or if there's kind of spasm of the muscles and things like that. So it's easy for me. But in general, you see how I didn't even know initially that am I supposed to perform a neurological exam or am I supposed to perform a hearing problem? What is the problem? So just don't get lost. When you see the case, if you don't know anything, just attack the main place where you're supposed to see that chief complaint from. Anywhere. Okay? Then you will figure out, oh, I see. I'm going this way. Then, and you have enough time. 8 minutes is enough time to go all over the body sometimes if you're lost. But at least when you go to your initial chief complaint position, that will help you much. Like let's say if this patient, for example, if you had to do a respiratory exam and you didn't know you had to do a respiratory exam, all of a sudden the patient comes to be having mass in the neck, masses in the neck, perform a physical examination for that. So I don't even know what's going on with this guy. How would I know? But the only thing I know is mass. Now I don't even know, is this mass related to some sort of HIV related question? Is it tuberculosis? Is it some sort of infection? All I have to do is go first, inspect, palpate, check for any palpation, inspection, and then check for the other lymph nodes around the area. And then after that, go ahead, perform some sort of like, auricular lymph nodes, and then listen to the lung sounds, listen to the heart sounds, as well as perform lymph nodes around the groins and check the lymph nodes around the other parts of the body that might be present. And then now I know that, okay, at least I took care of the main complaint. But before I even come to do that, I want to come up with a differential. Let's say if the patient was having mass in the neck, I should know, okay, is this thyroid? Is this a lymphadenopathy or cancer? Is this some sort of like, infection? At least I have these three things in my mind when I see a mass, right? As long as you have these differentials, it's so easy for you to perform a physical exam. But in general, at least you should know how to ask questions. This is what I'm teaching you today, is I'm teaching you the method on how to say things very slow and professionally. Don't say like, oh, one thing at one time and one thing at another time, and then, kind of you don't wait for the examiner and your words are all over the place. Say everything. If it comes to palpation, say everything at once. Don't hesitate to stop and ask too many times for palpation kind of questions. So anyways, so I hope you guys are understanding that point. If you're understanding that, then we can move forward to a little bit more of a respiratory condition, respiratory basically test, the special test. So special test in respiratory is egophony, wheezing, pectoralici, chest expansion, and basically listening to the lung sounds, and then check for some peripheral edema if you want to make sure that you exclude the possibility of some sort of heart failure. And of course, you have to go and listen to the heart sounds from the front and the lung sounds from the front, okay? That's another thing. Again, I will just go posterior chest. The way that you do it is you start from top to bottom, or you can go from the posterior chest. Let's say if you go from posterior chest first, you just go inspect the posterior chest by saying symmetry, bruising, skin changes and deformities, palpate for tenderness and temperature, and then you do a vocal tactile firmness, and then after that you perform a percussion, auscultation, and special test. So this is good, and then you go to the eyes, to the nose, to the mouth, to the neck, to the hands, and just check for peripheral edema. That's all. Okay, so I'm hoping that everyone's understanding what I'm trying to say, but I will send you, because I can't explain everything right now, guys. We don't have enough time. We have to also learn about the counseling as well as the management problems that comes with management, right? So I can't focus so many on each single aspect of this respiratory issues, but just when I send you these things, look over it, read over it, try to memorize it as much as you can, and practice it over and over and over and again until you become perfect in it. And you still have a good amount of time. 7 days should be okay to perform at least 10 cases a day. You'll be perfect. Okay, so when it comes to abdominal cases, same procedure as we said. The general occurrence for abdominal pain is basically you're looking for signs of excruciating pain or guarding in a patient. And then you will go ahead and say, I would like to ask my patient to have their hands by their sides. And then you will go and start your inspection. Look for symmetry, contour, distension, scars, visible mass, and paraumbilical veins. And then wait. Then I'll ask my patient to turn his head to the left, and then I'll ask him to cough for me to see if there are any bulging hernias, okay? And then you auscultate for bowel sounds, renal frequency, and for pitch and frequency, okay? Renal and iliac buoys. You do perform percussion, and for percussion, you perform it on all 4 quadrants for like basically tympany and dullness. So that's it. Abdominal exam is very easy. A lot of you do. One thing about abdominal exam is that's different with just like the others compared to cardiovascular and respiratory. And I believe you all know it's basically, what do you call that? Auscultation. Make sure you do not miss auscultation in an abdomen first and do the auscultation later, because you don't want to touch the bowel sounds later on, okay? And other than that, I believe like there's not much, but except of